I'm going to review neuropathic pain just briefly and show you what's in the module. So the symptoms of neuropathic pain, there are a few videos from less than a minute to about 5 minutes. You can watch them or not watch them as you prefer. There are some tests listed here for detecting neuropathic pain, somatosensory testing, and what the normal response is versus the neuropathic response. That is just there for your information. That's not on the exam, but sometimes, hey, how do you know you have allodynia? So there you go. There's a test for allodynia. So the 4 mechanisms of neuropathic pain, and I had 5 in the PowerPoint, the 5th one being pain matrix dysfunction, which is what we're going to talk about next. So the 5 message, there's a 10-minute video on central sensitization. If you want to take a look at that, optional of course. The sites of neuropathic pain, peripheral versus central. There's some videos on treating a patient with a phantom pain with mirror therapy, which is pretty cool, and a little 4-minute video on phantom limb pain. So we're going to talk a little bit about phantom limb pain, and then we're going to go right into pain matrix dysfunction. So pain matrix dysfunction is another way of saying altered top-down regulation. So phantom limb sensation usually refers to individuals who've had a limb amputated, but they experience sensations that seem to originate from the missing limb. Phantom sensation, so you can have any kind of phantom sensation. A phantom sensation that is painful is called phantom pain, and it's pretty uncommon, but people do have it. Phantom pain can be differentiated from residual limb pain. Treatment for residual limb pain is different than for phantom limb pain, but there's that video in the module about using mirror therapy. And I've used mirror therapy with people in the clinic with pain after a CVA, with amputees of phantom limb pain, and it's actually pretty effective. There's another graded, mirror therapy is sometimes part of what's called graded motor imagery. There's another graded motor imagery application that we use in the clinic where I work. There are apps that you can download on your iPad or your phone that are called Recognize, and it's the person is shown pictures of left and right feet, left and right hands. There's one for back, there's one for neck. There are lots of different modules of it. So say someone had phantom pain in their right foot. By doing these where you have to say whether it's the left or the right, it actually helps reorganize your brain mapping for that injured side. And it's really actually cool. And a lot of times too with orthopedic injuries, your brain map is a little bit messed up too. And so if I have someone, say I have someone who had an ACL repair, and they come in and maybe we do some manual therapy, we do some exercise, and then we put them on ice, and while they're on ice, I will have them do that Recognize application, or I'll give them a copy of Sports Illustrated and have them take a Sharpie and circle all the right legs that they see, if it's the right leg that's the affected leg. And the idea is getting your brain to recognize that leg as functional. So the Sports Illustrated is, or any kind of magazine where it shows people's legs, is a nice thing to give people for homework. You can have them do it while they're icing, because why waste that time? You could be doing some valuable neural re-education while they're sitting there on ice. So using that graded motor imagery application or mirror therapy, or doing just as simple as recognizing pictures of right or left arms or legs. Had to pause the lecture there. My phone was ringing. Okay, we're back to phantom pain. So there are some effective treatments for phantom limb pain in therapy, so that's pretty cool. So central pain is caused by a lesion of the central nervous system and is usually localized to the area body deafferented by the lesion. So you can have central pain after a CVA or a brain injury. Neuropathic central pain usually refers to burning, shooting, aching, freezing, or tingling pain. I see this a lot in my CVA patients. Spinal cord injury central pain, the thalamus may be the site of pain generation because after an SCI, the neurons in the VPL, which is one of the thalamic nuclei, are spontaneously active without input from the spinal cord. So some of the input that you would have been getting from your peripheral areas, you're not getting them because you have a spinal cord injury. The highway's closed. And so the thalamic nuclei may be spontaneously active without input. In MS, central pain often depends on the location of the lesion. So you're going to have varying locations, and that's why you have a lot of variable symptoms with MS as well, because of different locations of the lesion. So we're going to start talking about pain matrix dysfunction now, and that's that altered top-down regulation of pain. So top-down regulation of pain is disturbed when the pain matrix malfunctions. So when we talked about what the pain matrix is in Chapter 7, it's a lot of things, right? So anything that disrupts any of those areas can disrupt the pain matrix, and it can alter your top-down antinociception. So antinociception is reduced or pronociception is intensified, and the result being increased pain. So fibromyalgia, episodic tension type headache, migraine, and chronic whiplash disorder all involve the disturbance of top-down pain regulation. So we're going to talk about those individual areas, and we're going to talk about different types of headaches and some of those different areas because it's an interesting application of pain matrix dysfunction. So the disorders aren't caused by structural lesions in the periphery, so that's why they're considered neuropathic pain. So with fibromyalgia, so if we break that word down, fibro is fibrous tissue, like connective tissues, myo is muscle, and algos is pain. So it's pain of connective tissues and muscle. So people with fibromyalgia often have tenderness of muscles and adjacent soft tissues, stiffness of muscles, aching pain. The painful area generally shows up as a regional rather than a dermatomal or peripheral nerve distribution. So the fundamental problem is abnormal processing of pain information, resulting in the perception of pain without a painful stimulus. So basically the nervous system is creating its own pain, which kind of stinks. People with fibromyalgia have structural differences and abnormal pain processing. The brain in fibromyalgia has significantly less gray matter density in the pain-inhibiting brain areas, the medial frontal cortex, the mid and posterior cingulate gyrus, and the insular cortex, and in stress response areas. So for a while, fibromyalgia was thought by a lot of doctors and everything to be a psychological problem. It is not a psychological problem. It's actually a structural problem. They have objectively real structural and functional brain abnormalities. A large majority of people with fibromyalgia are psychologically normal. It can, because of the pain effects, it can lead to depression and anxiety. But the depression and anxiety don't cause the fibromyalgia. The fibromyalgia causes the depression and anxiety. So you will run into doctors out there who still think that fibromyalgia is a psychological disorder. So really it's up to us to educate as many people as we can. It is not a psychological disorder. It is a real structural and functional brain abnormality. Pain inhibition areas are significantly less active, and pain inhibition is impaired. So this is a functional MRI picture from the book. People with fibromyalgia have impaired descending pain inhibition. So altered top-down control of pain. Regions of the brain where healthy control subjects have significantly more activation than people with fibromyalgia when both groups subjectively report equal pain. So the functional MRI studies are the people with fibromyalgia, more stuff lights up in their brain. They have more activation than people who don't have fibromyalgia. So there is a boatload of information on the internet about fibromyalgia. There are a couple little videos here. We have a fibromyalgia education program at our at the clinic where I work. It basically is comprised of therapeutic neuroscience education. We educate people about their pain. We talk about relaxation and breathing and exercise and sleep hygiene, nutrition, and different, basically we give them a toolkit that they can use to manage their pain. Some people benefit from manual therapy, but manual therapy is not going to fix their fibromyalgia. So what we try to do is give them tools for managing their pain. Sometimes our treatment also includes aquatic therapy, but while they're floating around in the pool, we are also doing therapeutic neuroscience education. So it's really interesting. Some of the materials we use for our program are the Adrian Lowe materials. He's got a nice little patient education book that's called Why Do I Hurt? And that's part of the materials that we give our patients. He's also got some interesting books that are patient education ones. One of them is called Your Brain is Having Knee Surgery and Your Brain is Having Back Surgery. So it's just education of how surgery can affect your pain control systems. Very interesting stuff. So besides fibromyalgia, and also you can think of fibromyalgia, I'm still going on about fibromyalgia, you can think of it as being a hypersensitive nervous system. Your pain sensitivity is turned way up, and anything can cause it to flare up the pain. So part of what we teach people in the therapeutic neuroscience education program is how do you turn down your pain? What are the things that turn down your pain? Exercise is something. Heat and cold modalities sometimes. Doing pleasurable things that you enjoy, like listening to music and spending time with your friends and family. Binge watching your favorite show on Netflix could possibly be considered. I was visiting my sister in Western New York this summer. She owns a yoga studio, and one of the things that she does, there's a historic lighthouse right there on Lake Erie, and last year she started doing sunset yoga at the lighthouse, and the class fee that people pay, I think it's $10, but half of it goes to raise money for the lighthouse and half of it goes to the yoga studio. Well, when I was there visiting, I went to sunset yoga at the lighthouse because it's a do not miss activity. And I was talking to a woman in the class afterwards as we were watching the sunset, and she told me she had fibromyalgia, and for 5 years she did nothing but sit in her recliner and take pain medications, which did not help. She was miserable. And she saw a flyer for the sunset yoga, and she said, you know what, I'm going to go to that. She started going to sunset yoga, and it was the sunset that brought her in, and the yoga is what made her stay. Eventually she ended up she goes to classes 3 to 5 days a week at the studio, as well as going to sunset yoga. And so we were standing there at the top of the lighthouse watching the sunset, and she said, you know, a year ago I would have been missing this, and now I have way less pain. I'm not taking any pain meds, and I'm here watching this. So by doing something pleasurable and a nice activity and moving her body, she was able to decrease her pain and get off pain medications. So it just goes to show you, it's not always physical modalities or pain medications or anything that control pain. You can use other things to control your pain. So I'm going to wrap this section up, and then we're going to talk about headaches and some different types of pain syndromes.